Welcome to Skin Sync, the official podcast of Elevate-Derm Alliance, your trusted source for the latest in dermatology for PAs and NPs. Join our hosts for real clinician perspectives and expert guest insights as they explore everyday dermatology topics with practical takeaways.
Hi, everyone, and welcome back to the Skin Sync podcast. This is Bucci Nita, dermatology PA from the Atlanta, Georgia area, and your host. And I'm so glad to welcome back Jennifer Connor, our behind-the-scenes producer and our co-host for this evening. Hey, Jennifer, welcome back.
Thank you, Bucci.
So tonight we're going to be talking about alopecia areata. I think we all know in dermatology we've seen quite an explosion of wonderful effective therapies after we went from having none at all. And I think, unfortunately, although we do have these wonderful therapies on the market, there are some clinicians out there in dermatology who are still reluctant to use them. So tonight we want to kind of just go over who's a good candidate, what are some of the risks and benefits, and put some of the safety warnings into context. And to do that, we do have a wonderful guest, Dr. Arash Mostaghimi. Dr. Arash Mostaghimi is a dermatologist, Vice Chair of Clinical Trials and Innovation, Associate Professor of Dermatology, Director of Dermatology Inpatient Service, and Co-Director of the Complex Medical Dermatology Fellowship at Brigham and Women's Hospital. He is board certified in dermatology, internal medicine, and clinical informatics. As a father of a daughter with alopecia areata, Dr. Mostaghimi is dedicated to clinical research focused on understanding the epidemiology, patient experience, and health system impact of his disease. He has developed multiple outcome measures used in alopecia areata studies and is actively involved in a translational research and clinical trials to develop novel therapeutics for patients with hair loss. I have had the pleasure of listening to Dr. Mostaghimi many times. He's a phenomenal speaker and great educator. I'm really excited to have you here on the podcast today. So welcome to the podcast, Dr. Mostaghimi.
Yeah, so thanks for having me on, and thanks for highlighting this important topic. Hair has come a long way. A few years ago, we really had nothing for these patients, and now we have a few different options. They're all in the JAK family, and we'll talk through the use of those medications and when to apply them. But it really all begins with the idea of understanding how much your patient is impacted by their alopecia and when is it appropriate for them to go on a systemic medications.
I think we all just got introduced to the SALT score just a few years ago, at least those of us that are not in clinical research. And so, are there other tools, other scales that you utilize to help assess severity in patients?
There's a couple different answers to this question. If I was making an outcome measure for alopecia areata, I would actually not have any hair loss requirement in that measure. I would purely do it almost like depression. How much is depression affecting you? However much you say is affecting you, right? Because the primary issue for patients with alopecia areata is psychosocial outcomes, right? It doesn't really hurt, it doesn't really itch. Those are a very small minority of patients that have physical symptoms. But really, the disease in alopecia areata is one that affects your self esteem. It affects your self actualization. It affects your ability to portray and display yourself to the world as you wish to be seen. That in turn causes you to limit a lot of your function, interaction, activity, and also generates stigma that other people feel against you. So that is really the experience of alopecia areata. Now, for some patients, particularly patients who've had alopecia areata for a long time, maybe they have no hair and they don't care, right? We see some of these patients in our practice. We meet them, they don't want treatment, they're happy, they're moving on. That's fantastic. We're not trying to pathologize something that's not impacting them. But on the other hand, we all see patients with very minimal amounts of hair loss who are profoundly affected, right? Who, drop out of school, refuse to get married, don't want to go out on the date, don't want to give that presentation. And the cumulative impact of these across your personal life, your work, your social life really adds up to impact these patients substantially. So the first thing I would say that when I'm assessing a patient, I don't care about these tools per se. I'm really trying to connect with the patient and understand how is this disease impacting you. We can use the general amount of hair loss as a proxy for that, but if a patient has a small amount of hair loss and they're really impacted by it, I will treat that patient more aggressively than I'll treat somebody that really has no hair but doesn't seem to care. Right? I'll talk to all of them about the options and the treatment paths and things that they offer, but I don't have a strict cutoff in my brain for, what's severe, what's not severe. Historically, what's been used is the SALT score. So the SALT score you just mentioned is a funny instrument where it's not about how much hair you have, it's about how much hair you've lost. So SALT 100 means you're totally bald, and SALT 0 means you have all of your hair. And the reason that we bring it up is that in clinical trials, so not in the clinical setting like when I'm seeing patient, but in trials, the way they assessed inclusion in trials was to say that you had to have lost over 50% of your hair. So have a SALT score over 50 to be considered severe. And then the outcome they had for success in the trials was SALT less than 20, meaning that you had lost less than 20% of your hair or regrown, at least 80%, right? Depending on how you want to calculate that. So that's an important place to start. But I always tell the person, show me the person that has 48% hair loss and feels good about, their hair. Things like they have great hair. That doesn't exist, right? If you're losing 10% and you lose that right in the front of your scalp, that could be much more impactful than losing the entire back of your scalp where it could be easily covered, for example, right? Things mean different things to different people. So I do write a SALT score in my notes. The reason I do write the SALT score is I write it purely for insurance purposes. So the one thing that has happened for insurance companies is that they're really using the SALT score to say that you qualify for this medication if you could qualify for the trial. So for the majority of places in America, you have to document a SALT score over 50 to get this medication. You don't have to be that precise about it. In reality, you don't have to be even that good, and you can fudge the numbers a little bit if you want, right? Nobody's going to be double checking your scoring here, right? I say I'm never as bad as math as I am when I'm calculating a SALT score. But the reality is that so I don't document like SALT 58%. I document SALT greater than 50, and I just leave it at that. And when I want to document success, I document SALT less than 20 or full regrowth or something like that, just so when they're looking at that, the insurance company knows exactly what they're seeing and they move on with it. But as I said, that doesn't really capture the experience of patients. There's a different measure called the AASC, which is a way of trying to take this holistic view that we take of patients, right? Trying to interpret the feelings that patients have into a scoring system that we can then use to justify that insurance is what we do. The AASC, it starts off with the SALT score. So SALT over 50 is automatically considered severe. 21 to 49 or 20 to 49 is considered moderate, and then below that is considered mild, right? So you have mild, moderate, and severe. The one thing that the AASC score does is that it allows you to bump up one notch if you have one of four things. If you're rapidly losing your hair, if you're not responding to therapies over the course of 6 months, if you have significant psychosocial impact, or if you have facial hair involvement, meaning eyebrows, eyelashes, and even beard, right? Those are the areas of the body that affect people most when they're lost. So if you have between 20 and 50 in one of those, you can bounce people up and call them severe. Now, I'm using that score and the SALT score together. I'm documenting both in my notes. We have some upcoming joint guidelines from the National Alopecia Areata Foundation, the American Hair Research Society, which use this score to determine severity. So we're hoping that this is where the world goes and is a better way of really assessing these patients over the long term. But for now, I think for documentation, for getting the drug, the SALT score is really what you have to document and move forward with that.
Biggest shifts I think we've seen in dermatology is how we define disease severity. And I think back to psoriasis, at least when I started clinical practice years ago, that we would rely so heavily on body surface area and we'd reserve these systemic therapies for patients that had really high involvement. And nowadays, that thought process has shifted, and we're utilizing systemic therapies much earlier in patients who may have limited BSA, but obviously, if they have more psychosocial impact, if they have psoriasis in those high impact sites, if they have more severe symptoms, I think we're shifting to systemic therapies much earlier. So, my question is, do you feel that alopecia areata is kind of undergoing a similar shift? Because when the JAKs first came to market, I really didn't have a lot of patients where I was utilizing these JAKs because I didn't have patients who had really high SALT scores. And, I think maybe my understanding of who's a candidate was a little skewed back then. And now that I've learned so much more, I have plenty of patients who actually have maybe more moderate disease, but the psychosocial burden's higher. And perhaps, they have other areas of involvement like their eyebrows. So do you feel that shift is going to happen in alopecia areata?
Yeah, we're going to be in the exact same ballpark with alopecia areata. So when I was a resident, and biologics were first coming out, I'm really dating myself for the people on this podcast. Basically, in order to be a candidate for the biologics, you had to be erythrodermic. You had to have like 80% body surface area, and then maybe you would start somebody on Humira, right? At that time, adalimumab at that time. So now, if basically somebody has 7, 8%, they're slightly annoyed at using creams, or as you said, is in their scalp, their palms, their face, their genitals. We have this concept of special sites, right, that impact you more, even if the body surface area is low. We realize that the benefits of these medications can be super high, and we also realize that the risks of the biologics over time People may find this funny, but at the time we were really worried about cancer risk with biologics, and now over time we realized that's not really the something as significant as we worried about. So over time, as the benefits of treatment are better realized and the risks of the medications we have, we realize they're not as risky as we thought. That risk benefit ratio changes, and we have to think more broadly about who we're willing to treat. So for alopecia areata, we're in the early innings, right? We're just starting this road, but we're also looking at trying to define special sites. We're trying to reassess severity and really try to align the patients that we're treating with the patients who could get the most benefit based on really our holistic experiences in clinic.
Yeah, I think it's interesting when you've been practicing long enough to really see those paradigm shifts in therapy and just how we view disease, much like we have in psoriasis, like you mentioned. And so I think having new guidelines for alopecia that take into account the rapidity of hair loss, the psychosocial impact, whether they're losing hair on their face and the eyebrows or the eyelashes, all of those things are so important. And there's one patient in particular for me that sticks out, a teenager that I was treating for alopecia areata, and at that point, we didn't have an FDA-approved JAK inhibitor that I could use for him, so we were just doing intralesional Kenalog, but his father was also an alopecia areata patient, alopecia totalis, actually. He'd kind of been through the ropes and been through some clinical trials, but this kiddo religiously was coming to see me during COVID, and he finally regrew all his hair. And I don't think that I realized the psychosocial impact until that patient and his dad came back and his dad said, "Hey, can I take a picture of the two of you?" He's like, "This is so big for him. His life has been changed." And I thought, "Wow." When he came in, if I had done his SALT score, I don't know what it would have been. It wasn't over 50 for sure. But this kid was so impacted, and this dad who also has alopecia areata saw the change in him from that standpoint, and so that was really impactful for me as a clinician to see just how much it can affect those patients.
I think that's a great story. I think it's amazing and profoundly rewarding to take care of these patients, particularly when they're younger. You often don't realize the impact it's having, and then when they come in and their hair is regrown, it's almost like you reboot your computer and all of a sudden it magically works, right? You don't realize how much impact there was on them before. They've people that young kids that wouldn't look you in the eye, wouldn't talk during the visit. You ask them about school, they wouldn't really answer your questions or give you one word answers. All of a sudden, their personalities emerge, right? Their humanity emerges, their comfort. And when you think about it's really at any age, but if you really think if you're between 10 years old and 30 years old, you're trying to figure out who you are, how you fit into the world, how people relate to you. It's already hard enough to go through middle school, high school, make those relationships, enter romantic relationships, really put yourself out there. And if on top of that, you're having this aspect where the person you look at in the mirror doesn't look like you, or you feel people are judging you or questioning you or thinking about you in a different way, it really has it's just like a noise constantly in the back of your mind that is dramatically limiting you. And I've even had patients, Jennifer, tell me that they didn't realize how much it was impacting them until they felt better and realized what a weight had been lifted. Even the small things. I was able to walk outside and it was windy. I didn't worry that my hair was going to fly out of the way. I was able to go to the beach for the first time. I went in the pool with my kids and I wasn't worried that you could see my scalp. Oh, I can get up 20 minutes later every morning because I'm not putting on my eyebrows for 25 minutes every morning or this type of thing. It really can be amazing for these patients and a real gift.
So when we really think about just how impactful psychosocially alopecia areata can be, it really brings to light how monumental it is that we've had the development of 3 new FDA-approved JAK inhibitors in this space in the past few years, and we'll kind of dive into that next.
For clinicians who may not be using these drugs regularly, could you just walk us through the three approved therapies and highlight what makes each one unique?
So we after having no drugs for all this time, we got one FDA approved drug basically every year, several years in a row, right? And the three FDA approved drugs for alopecia areata are all JAK inhibitors. They are in order of how they came to market: baricitinib, ritlecitinib, and then deruxolitinib. And I don't know if we're the name brand kind of podcast here, but I'm just going to mention name brands once so people know how to connect them. So Illumiant is baricitinib. And then Litfulo is ritlecitinib, and then Lexelvi is deruxolitinib. So the best JAK inhibitor for your patient is the one that you can get that insurance will pay for. Okay, so that's basically the bottom line. They're all in the same class, right? So they all share the same black box warning. We'll talk a little bit more about that and the safety profile and picking medications from that standpoint. But the most important thing when you're starting these medications is that you really talk to your patients about realistically the benefits of it, realistically the potential downsides, realistically the time frame, right? They work slowly, right? Everything in dermatology works so quickly nowadays. We're so spoiled, but this may take 6, 9 months to really see the benefit. And finally, something that is radically different. And for your listeners, if they take one thing out of this that's different than what we get out of the that's different from all the other diseases that we treat, is that if I saw you guys and you guys had psoriasis and you said, I don't want to go on a biologic, and then 3 years later you went on a biologic, you'd be fine, right? Eczema, same idea, you'd be fine. The clock is ticking when you have alopecia areata. So when you have alopecia areata and you lose over 50% of your scalp, we know that if you intervene in the faster you intervene, the better you are in terms of how much hair you're going to grow and how quickly you're going to grow it. And also, that's only going to last. That efficacy of those drugs changes dramatically at the 4-year mark. So this isn't something that you can hang out and think about and go back and forth on and come to eventually. The clock is ticking. So if patients don't know, they should always err on the side of action because they can come back to it later. They can stop the treatments later. If the treatments don't work, they can do that. But study after study after study has shown that the earlier you treat is better. So the best JAK inhibitor, the one you get, the best time to start it is when you're ready to start it, ideally within 4 years, so you get that best treatment. Well, walking through some of the specifics of these medications. So baricitinib is a once-a-day medication. It's a JAK1/2 inhibitor. It has the benefit of being the oldest medication on this list. It is a medication that was out in Europe for atopic dermatitis and rheumatoid arthritis. It's been out in the United States for rheumatoid arthritis and there's like 10 plus years of safety history. So when people really want to know what the safety is of these medications, you can say, look, baricitinib has been around for 10 years. We really know a lot about this medication. So we have a lot of good safety signals for long-term risk of cancer, long-term risk of clot. We can talk about all those things with those patients. It comes in 2 doses. It comes in a 4 milligram dose and a 2 milligram dose. Honestly, the 2 milligram dose is underdosed. Okay. You should try to start everybody, regardless of salt score, even salt below 95. You can start everybody on the 4 milligram dose. It'll work better. It'll work faster. The only difference between them is the number of laboratory abnormalities, but no clinical side effect differences. So you're not getting more clot or more infections or anything that you really care about. You're just getting some mild laboratory abnormalities. So that's baricitinib. Baricitinib is approved for again, some severe disease, which is identified by insurance companies as over 50, but hopefully our new definitions we talked about will change that a little bit. And it's for 18 plus, so they have adolescent data, and hopefully it'll be approved for adolescents soon. The next drug, Elevate-Derm, is a little bit different. It's a once-a-day medication. It only comes in one dose, 50 milligrams. It's a JAK3 inhibitor. It's a JAK3 tech inhibitor. So when it doesn't impact JAK1 and JAK2, some of the things that are different about it is that it's a little bit cleaner when it comes to the laboratory monitoring and impact. So it doesn't impact lipids. So some of your patients who may be obese or overweight or have lipid problems, this is a medication that really has minimal impact on lipids, and you don't have to monitor lipids while you're on it. So that's one of the benefits there. It's also the only medication that is approved for the 12 to 18 years of age. So it really is the go-to medication for adolescents. So one pill once a day, it works. It works well. There also is an ongoing trial to think about higher doses of ritlecitinib. So you may have in the next couple of years an option to use different doses, much like you use in baricitinib. The third drug, ruxolitinib, is a little bit more complicated to use, but may be better for your patients in terms of how well it works and how fast it works. So ruxolitinib is a twice-a-day medication. It comes in one dose, 8 milligrams. So you have to take, and it really is a twice-a-day medication. They studied it once a day versus twice a day. They doubled the dose and took both pills at once. It really doesn't work well as a once-a-day medication. It works beautifully as a twice-a-day medication. So you have to make sure that patients are understanding of that and willing to take that. One difference between it and the other medications is that it is metabolized by a specific enzyme in the liver that requires testing before you start it. So if you're planning to start your patient on ruxolitinib, you need to get this test company, Sun Pharmaceuticals, will pay for the test, and they have information on their website on where and how to get that test. It's an added step, it's an added checkbox, but a lot of patients like the idea that it shows that they're going to be safer while taking the medication or that they metabolize it appropriately. Only a very small percentage, 1 to 2%, maybe 3%, are going to be poor metabolizers and won't be able to take that. When you do that test and it comes back on the test, it'll be written whether they qualify to take the medication or not. So the advantage of Druxolitinib is that both in terms of speed, how fast you grow hair, and potentially how the depth that you grow your hair, it looks like it may be slightly better than Ritlecitinib and Baricitinib. So this is a medication that I often use for people that are may say they're losing their hair and I have a wedding in 9 months or something along those lines. I want to look like I normally do at my son's graduation. Anything like that, this would be a great medication to go to. Or somebody that is just truly saying like, I want my hair yesterday, like I can't deal with this, and they're willing to go through the added step of the genetic test and the extra twice a day medication. But I'm really happy with any of these medications. I know I've been talking for a long time. I'll say one last thing I want to say about these, right, is that what's really different about JAK inhibitors versus other medications is that if you, for example, had a patient on an IL-23 for psoriasis and they didn't do well, you wouldn't give them another IL-23. You switch them to a different class. You switch them to an IL-17, for example. That's not the way that it is for JAK inhibitors. So Druxolitinib is a JAK1/2 inhibitor. So is Baricitinib. If you fail Baricitinib, it's totally normal to go to Druxolitinib and you may get a different response. The inverse is also true. You can go from Druxolitinib to Baricitinib. The way that these work, and with Ritlecitinib anywhere in there, first, second, or third, whatever order you want. If you tried one JAK, you tried one JAK, right? There's something probably about metabolism more than the actual inflammation of the disease or the nature of the disease that's guiding this. We don't quite understand. But it's not necessarily intuitive who's going to work with what. So you try one. If it doesn't work, you just move to the next one.
So what does your conversation look like with your patients when you're starting them on a JAK inhibitor compared to, we used to use so many intralesional steroids or sometimes even systemic corticosteroids for alopecia areata simply because we didn't have any other option. So can you take us through what that conversation looks like in the clinic?
I will tell you exactly what I tell my patients. I'll walk you through the script because I think people have a sense that this conversation takes a long time and it doesn't have to, right? First, you don't have to have all the conversation in one sitting, right? You have to just make it to the point where you're making a decision as to what the next steps are and get there. And then, secondly, it's you're because you don't have to get it all done at once. You can revisit it over time, right? So the normal conversation is you mention these medications, and then people are like, "Do I need to be on it for life? What happens in 10 years?" Like all these types of things, right? So how I present it is say, look, we have only one group of medications that is known to work effectively for alopecia areata with disease as severe as yours. They're a medication called the they're JAK inhibitors. They block a process in your inflammatory cells, a pathway called the JAK-STAT pathway. And that JAK-STAT pathway, we know from genetic evaluation, is abnormal in many patients with alopecia areata. And they have abnormal activity in it, which leads to the inflammation that's making your hair fall out and keeping it from growing back. Taking this medication reduces the inflammation, and then it allows the hair to grow back over time. Now, the tough part is that the inflammation is under the skin. You can't see it. So the medication makes the inflammation go away. And then after that, your hair still has to go back into cycle. So there's a delay between when the inflammation goes away and then eventually your hair comes after that. And for some people, that can be pretty quick, and some people it can take a long time. But you have to think about it like a garden where you plant the seeds and you water it. It takes months and months, and then all of a sudden, wow, you have a garden, you have fruits, you have vegetables, you have flowers. This is going to take some time. And then, Jennifer, when I'm having this part of the conversation, so we're recording this right now in May, right? I will give them specific times. So I'll say, we are going to be happy if we see improvement by Thanksgiving, right? We're going to be happy. And we may not make a decision as to whether or not this is the right medication or not for you until 9 months from now, Valentine's Day of next year, right? And they're like, wow, Valentine's Day of next year feels impossibly far away, right? We have to, from the very beginning, set the standard for what this is going to be and how long they need to be on it and how patient they need to be, because you don't want somebody coming back after a month and saying, what happened? My hair's not here. I'm frustrated. They're calling you. They stopped the medication. You really have to set those expectations up front. So when it comes to the safety of the medication, they say, look, all medications have side effects. This is a medication that reduces your immune system. The good news is that, and this is true for all these medications, or they're slightly modified depending on which one you're picking, but say for all these medications, the more we know about them, the better we feel about the safety. So the earlier JAK inhibitors, specifically one called tofacitinib, which we might get into a little bit later, was one used in higher doses for patients with rheumatoid arthritis. And in those patients, they identified several medical problems. And as a result, every single drug in this class has a box warning on it. And when you read this box warning, you're going to think that you're crazy for taking the drug because the box warning is going to say you're going to get a clot, you're going to get a stroke or a heart attack, you may die, you may get cancer, right? It's going to have all these awful things. But that's not coming from these medications specifically. That's coming from the first generation, a different version of these medications. Now, the risk of those is not zero. We have to monitor you. We're going to do blood tests. We're going to do laboratory evaluations. We're going to make sure that longer term we have better safety data and understand that. But for now, this is really your best option. And then this, when they usually ask, do I need to be on these drugs for life? Or, what happens? What if what happens if I stop the medicine? And the way I circumvent that conversation, I was like, these medications are intended to be long-term medications. But, we don't know if they're even going to work for you yet. Let's see if you take them, see if you like it, see if you tolerate it, see if your hair regrows, see how you feel when your hair regrows. And then depending on how that goes, this may be a drug that you continue on for a long term. And maybe there's a drug that you continue on. And then over time, as different options come, we transfer you or transition you to other options, right? I say we're not talking about marriage here. Let's go on a date first. Let's figure out if this actually works for you yet. So all those are honest. I'm not understating any of the things. And people, I live in Boston. There's like half my patients have PhDs and or this and that or whatever. They'll ask me specific questions, and some of them want to go through the data and things along those lines. But basically, they want you to show that you've thought about it. You're going to acknowledge that it's a commitment. You're going to try to modify risk as much as you can with laboratory evaluations, et cetera, et cetera. You cannot promise them either that their hair is going to come back or that they're not going to get a clot. These things happen, right? But what you can say is that in general, we understand these medications better. We have a sense of their safety. And, we're going to keep a close eye on you and a close eye on the literature to see if anything weird shows up or comes up. And that's when a drug, for example, like baricitinib is helpful for some patients. You can say, look, although, we've only been using these for a few years in alopecia areata, and somebody's sicker, like rheumatoid arthritis, we have, 10 plus years of data and these patients are doing okay. So we think that in a healthier group, a healthier population, like, the patients with alopecia areata, they'll do even better. So that's the general gist of the conversation that I have. Once you have that a couple times, I'm not one of those doctors that has like a 45-minute intake for my hair patients. I see 22 patients in a half day. My new hair patients are, 15 minutes long, maybe if they're lucky. And I have that conversation. The one thing I do that might be different from my colleagues is I bring them back again at 1 month in person, right? And I do that because I do their labs at 1 month to see how they're doing. They don't need to see me to do their labs, but I repeat probably 60% of that initial conversation because they don't hear it, right? I do it again. I talk about the time frame again. I do all of it again. So basically, I have like 2 12-minute conversations that are not torpedoing my clinic, right? Because I'm not going an hour long and in these rooms, this type of stuff. I have 2 12-minute conversations a month apart. The patient's confident. They know what's up. They may have additional questions after they're reading something or doing something at home or things along those lines. And it doesn't impact my clinical flow. It also makes them feel heard, cared for, taken care of, those types of things.
At this point, how to have the conversation and how to convince my patients that a JAK is the right thing for them. But I've had a few incidents where patients want to discontinue the medication, not because it's not working, but because they're having some perceived side effect. And oftentimes I feel like the counseling and the education can cause issues because patients are now hearing that they might get more colds or more infections. And so everything that they experience, like a respiratory infection, they'll perceive it as a side effect of the drug. And you can't tell them that, it's not from the medication, but it's just really hard to have that conversation. So what's your approach to that patient who thinks they're having every adverse reaction that's listed on that label? How do you convince them to stay on therapy?
So this is super important because if you tell them it's not from the medication, they never believe you, right? Because they're like, it doesn't matter. I started this. Like, if you start this medication, it rains for 3 days, we're going to be like, oh, I set off thunderstorms with this medication, right? Like people, we like to believe what we see, right? That's pretty common. So if you tell them it's not that, you're going to then this is going to be a back and forth. And this is what you say. You say, look, I prescribe a lot of this medication. I'm comfortable with these medications. That's not a typical side effect that I see, right? But everybody's a little bit different. Why don't you stop this for a couple of days and we can see how you do that? I do think it'd be really important for you to get this test, take the antibiotic, go to primary care, whatever it is, X other thing that you need to do, because I don't want to blame this medication and miss something else that might be going on. That's all you say. And then basically sometimes they power through it. Sometimes they stop it for a couple of days, it gets better, they feel better. Other times they stop it and then you can even come back to it later. So maybe this person you're talking about today, maybe after a couple weeks, you're like, hey, we're not sure if that was really the impact or not. Let's try again. Let's start over now that you're feeling better and see what happens. If it's the same, then we'll move on. And if it's not the same, then we'll know it was something else.
Your comment about patients believing that anything that happens to them is definitely related to the medication, including rain or a thunderstorm, is funny because it's true. But our job, obviously, as clinicians, is to listen and to take that seriously, and to try to recenter the patient and make sure that they're not having some side effect that maybe we haven't considered. But then we have to kind of circle back and think about, how do we treat this disease and how do we move forward? I think you've got some great strategies for us and how we move forward, knowing these are patients that are more likely to respond to this medicine. So if we realize that the medication isn't the cause of the side effect, we get them back on the drug. I think that's even more important in those patients that we know are most likely to be good responders, right?
Predict who's going to be a positive response, who's going to have a strong response to the medication, who's going to be successful, or on the other hand, are there certain features that would make you believe that the patient's not going to do well with therapy?
The two major prognostic features are how long you've had the current episode. So let me describe what current episode means. Current episode means when you're stable in this position, right? So current episode, if I was like 7 years old and had alopecia areata, and then I lost all my hair when I was 20, and then it grew back when I was 23, and now I'm 45 and I've lost my hair for 2 years. That 2 years is the current episode, not 38 years or whatever it was from when I was a kid. So you're really looking at kind of that current episode. So treating aggressively fast, and then if they have more hair when you're treating them, those are the two things that lead to more benefit. Also, anything for adolescents, for all these drugs for adolescents, add like 20+% to efficacy. Adolescents respond much better than adults do. So they do really, really well across the board. So I don't wait for them. Like if they're losing hair and they're losing hair dramatically, I don't wait for them to cross salt 50. If I know they're going to be there in a month, what other disease do we wait for you to get miserable before we start? We know where it's going to go, right? That's why I round a little bit, as we were talking about before, get them started on the medication and move from there.
Do you even have the conversation now, having these options about interlesional steroids or other options? I mean, we know that the JAK inhibitors are far superior and actually FDA approved, but what does that conversation look like?
So there's a whole bunch of older medications, even I'm not talking about the steroids, but methotrexate, cyclosporin, all these types of azathioprine. These are things that really should not be part of your arsenal, and it's a very rare that we should be using them nowadays. They don't work very well, and then the risks of those medications are probably not that. They're not better than JAK inhibitors. So if you have something that doesn't work as well, and is not really safe in the long term, it's really hard to say that you want to use it. And unfortunately, we've done a lot of work. The National Alopecia Areata Foundation has to eliminate these as step therapy for these patients. So if somebody is encouraging, if insurance is encouraging for that, I think you can push back. And in our upcoming guidelines, that should support you in that decision making and promoting that decision making. Separately, for things like intralesional steroids or for things like minoxidil, for example, either topical or oral minoxidil, this is where there's a little bit of a variation between how different hair experts practice. Some people will start the minoxidil right at the beginning, oral minoxidil and JAK inhibitors, and they think it pushes them, makes them go faster, etc. That's probably true. I don't do that because a lot of my patients don't need to be on two medications, right? So if you grow all your hair back and I put you on both, I don't know which one you need, or do you need both? It's hard to remove one. So I just start with the JAK inhibitor, and then I will begin to reintroduce things like topical and oral minoxidil later if the velocity is not right, or the patient wants a little bit more thickness or growth or things along those lines, right? I stop intralesional steroids when I start these medications. I do intralesional steroids on patients that that do not want any JAK inhibitors. I mean, you can do a lot of intralesional steroids. I personally think that we underestimate probably the long-term impact of that much steroid.
There is definitely some new information coming out about cumulative steroid exposure over one's lifetime, whether it be systemic, intramuscular, intralesional, topical even. In the atopic dermatitis space, we're seeing some information about kiddos with early osteopenia and those sort of things. So I do think we need to be cognizant about steroid exposure even in our alopecia areata patients, which is where these JAK inhibitors coming onto the market really help us in moving forward. But even despite that, we have some providers that are more fearful of the JAK inhibitors than they are lifetime steroid exposure. But I think it's just like any new drug mechanism of action that comes to market, it takes people some time to become comfortable with it.
If you could, just very bluntly and honestly, just share with us any tips, any words, any messages that you have for those providers out there that are still refusing or that are still uncomfortable with prescribing JAK inhibitors.
A big difference between you being used to and comfortable doing something with it being safe. We like to think because we did it for a long time is safe. That those two aren't necessarily the same thing, right? We did it because we had nothing better to do or we didn't have an option. I do bring back intralesional steroids if patients, for example, are growing back their hair and have specific bald spots that they don't like. We can push it along, or and move things along that way. But it's again something I come to a little bit later. In our guidelines, we'll talk about the use of oral and topical minoxidil for eyebrows, for facial hair, for scalp. Topical JAK inhibitors don't really have a role in the treatment of alopecia areata. They don't work that well. They may work a little bit better in kids. They may work a little bit for eyebrows and beard. They don't really penetrate into the scalp consistently. So that's not a direction that would go down. And there are drugs like bimatoprost, for example, that can help with eyebrow and eyelash regrowth, also for beard regrowth. So there are these little like tricks of the trade and things you can do along the way. But usually I start with JAK inhibitors and just try to ride that as monotherapy before introducing new things over time. You're setting me up for some straight talk with my not just my APP PA colleagues, but really across the board in dermatology. If you are not prescribing your patients JAK inhibitors if it was your patient with severe alopecia, JAK inhibitors, I would even say the same thing for AD if you can't control AD with other things. If you're not using JAK inhibitors as part of your practice, it is your obligation to find somebody who will, right? You're doing a disservice for your patients. It's okay to feel uncomfortable with certain things. You need to evolve over time. New drugs, new therapies will come. For some of the people on this podcast, this might be the first time kind of a new drug in a new class has come. Fortunately, I'm not this elderly, but when clobetasol was first presented, right? When clobetasol first came out, it used to be there's a group of people in the community who felt it was too strong and would refer those patients to academic centers to start clobetasol. Okay.
Wow.
So dermatologists are risk averse. We don't like very much risk. We're not comfortable. We don't want to mess up our patients. The idea of first do no harm, I totally get. Right. And but you need to find whether it's in your continuing medical education, whether it's at these conferences, whether it's a trusted peer, whether it's somebody that you phone a friend when you need to. You have to come up with a place where you begin to evolve how you think about it. And that first patient for JAK inhibitors doesn't have to be like a 400-pound, smoking, somebody with a history of clout. It doesn't have to be that. It's a 22-year-old man, totally healthy, nothing else going on. Let's see how he does, right? So baby steps, begin to do it. Talk to your MSL, talk to your reps, whoever you feel comfortable with, phone a friend, and do it with somebody. Do it as a partnership. I have people that text or call me all the time. Hey, I'm nervous about this. Let's do it. I'm like, hey, let's do it together. After you do a couple, you learn how to do it. But if you don't evolve, medicine passes you by. The fun part about what we do is that we have new therapeutic, new ideas, etc. JAK inhibitors are not perfect. They're better than anything else we have in alopecia areata. And wouldn't it be awesome if we have treatments that are not JAK inhibitors that work even better and are safer, et cetera? I would love that, right? I would love for risankizumab of alopecia areata, where you just kind of put people on it, they magically get better, and they love you for it, right? You never have to check any labs, never have to do anything. And maybe we'll get there, right? But for now, this is what we have. And then going back to my other point, that clock is ticking, right? So if you don't manage these patients and fix them, it's not like 5 years from now they're going to go see somebody. They have a window where you can treat them. So I get it that people are scared. I get it that they're nervous. Baby steps. Start with people that you are the lower risk, the lowest risk that you're most comfortable with, and then expand from that. You don't have to know all 3 JAK inhibitors. Just pick one. Pick it out of a hat. Pick one. If you want to pick one for adolescents and adults, ritlecitinib is for both, right? So if you just want to pick one, that might be it. If you want to pick one that has the longest safety data, pick baricitinib. If you want to pick one that is, the fastest and you like the idea that you're getting genetic testing to make sure that it's safe for your patient, the ruxolitinib. It doesn't matter. Just pick one and begin with that and then roll from there. So that would really be my take home. And adjacent to that is going back to what you were saying at the beginning. We are seeing severe patients all the time. Don't just look at the hair count and do that. If your patient is impacted, if their lives are impacted, if they're socially being impacted, that's a severe patient. Let's make sure we do them justice.
Spinning off of that, and I know the answer to this, I think, to close things out, but as a parent of a child with alopecia areata, are there any things that you wish dermatologists or APPs in dermatology understood about this disease, or what is one thing that you would tell us?
So, my daughter lost all her hair when she was 5, and now she's 16 years old. And when she lost all her hair, she fortunately was not super affected by it, but I was super affected by it. My wife was super affected by it, right? It really was an unusual experience for us to go through. And I'm embarrassed at how ignorant I was in terms of understanding the impact this was having on my patients. Right? You described, Jennifer, your experience with this young man who you treated and he felt better. I just really did not appreciate the impact that this disease could have, not just on the patient, but across their entire caretakers, et cetera, until I had the experience with my daughter and went through that. We didn't have very good treatments for alopecia areata back then. I was nervous about it. I wasn't excited to treat that time. But now knowing if I knew now and had the treatments now that I did then, I think the best thing would have been to treat her more aggressively, because we didn't really appreciate that we had this limited window at that time. So the best things to know are really connect with your patients, connect with their family members, truly try to understand how it's impacting them. And really, you have to be aware that the fact you have this window, that if you cross that window and you're not successful in treating patients in that window, that their overall likelihood of having a good response seems to really diminish. And that's across all the treatments that we have.
Absolutely. Well, thank you so much for joining us.
I really appreciate the invitation. Thank you so much for having me.
I appreciate your expertise in bringing some clarity and knowledge to this topic. And I know that our listeners will walk away with some practical insights, and hopefully they can apply that to their own clinical practice. And thank you to everyone listening, and we'll see you next time.
The enduring content of this episode is sponsored by Sun Pharma.
Thanks for tuning in to SkinSync. Don't forget to subscribe to SkinSync on Spotify or Apple Podcasts so you never miss an episode. To explore more of Elevate's educational and career resources, visit elevate-derm.com. Please note, this podcast is for informational purposes only and not a substitute for professional medical advice. Always consult a licensed healthcare provider before making medical decisions. Clinicians must rely on their own judgment and training in all patient care situations.